So our next speaker today is Joshua Mersky. Dr. Mersky is a professor of social work at the Helen Bader School of Social Welfare at UW-Milwaukee. He also co-directs the Institute for Child and Family Well-Being. His research interests include child maltreatment and other adverse experiences that undermine health and well-being over the life course. He does much of his research in Wisconsin. So since 2011, he has headed the evaluation of Wisconsin's Family Foundation's home visiting program. He also leads the Healthy Families Study, a randomized trial of home visiting programs in Milwaukee, and the Families and Children Thriving FACT study, a longitudinal investigation of risk and resilience among low-income families in Wisconsin. He recently helped launch the Trauma and Recovery Project, a 5-year, $1.8 million project funded by the Substance Abuse and Mental Health Services Administration. And Dr. Mersky is a Badger. He received his PhD in social welfare from UW-Madison. When I asked him how he became interested in this area of study, Dr. Mersky joked that his career path he didn't choose his career path, that it chose him. So before going to graduate school, he worked for 5 years as a direct service provider with children and youth in community-based and residential settings. Almost all the children had significant histories of trauma. So today, his work focuses on translating what we know about trauma and its consequences into cost-effective and effective prevention and intervention strategies. He said he's particularly interested in programs and policies that are scalable, sustainable, and applicable in real-world settings. And very appropriately, his presentation will cover Scaling Up Home Visiting in Wisconsin, a 2-generation strategy to address trauma. All right.
Is this my clicky? Great. Good morning, everyone. Thank you, Heidi, for that wonderful introduction, for organizing this fantastic opportunity to come speak with you. I also want to thank you for being here, and I want to thank Dr. Fox for laying a very strong foundation for my presentation as well as Megan, so we'll be able to build an architecture on top of that. So as Heidi suggested, my title is Scaling Up Home Visiting in Wisconsin, a 2-generation strategy to address trauma. Most of my work does indeed focus on trauma and adverse childhood experiences. Many of you in the room, I know, have heard this term trauma, and it's been receiving a lot of attention, and for good reason. And I'm going to be talking about why we should be paying attention to trauma, and I'm particularly interested in thinking about what we can do about it, solutions. So much of my work with my colleagues at the Institute for Child and Family Well-Being focuses on not only the negative story of trauma, but also thinking about what we can do about it, answering that so what question. How can we translate what we know from the science that Dr. Fox talked about and translate that into meaningful practices, programs, and policies to help promote the health and well-being of children and families. So I'm going to make the case today that trauma is not only important, that it's a major public health problem. A couple generations ago, tobacco use in our society wasn't necessarily viewed as a public health problem. And now today, it's widely understood by everyone in this room that tobacco use is associated with lung cancer and many other unwanted health consequences. It's widely recognized as a public health problem. And it's only been within recent years, perhaps, that we've begun to recognize that trauma is in many ways similar to something like smoking, and that we need to think about it through a public health lens. Here's my evidence. Number one, trauma is prevalent in society. It is common. It is not a rare occurrence. We know from the adverse childhood experiences literature, not just the original adverse childhood experiences study, but hundreds of studies since that time, including some of the research that we've conducted, we know that it's common. Over 60% of American adults report that they have been exposed to at least one adverse childhood experience, like child abuse and neglect, domestic violence in the household when they were growing up, or parental substance use. So it's common. It's also consequential. ACEs, adverse childhood experiences, as Dr. Fox talked about, are a major source of toxic stress in early childhood that have long-lasting consequences. ACEs have been linked to an increased risk in heart disease, stroke, even cancer. Something that happens to you when you're 5 or 10 years old can be linked to negative consequences when you're 50, 60, 70 years of age. And what they've also shown is that the more ACEs you've experienced, the more adversity that you experience in childhood, the greater the likelihood that you are to experience these kinds of unwanted outcomes. And it's not just health outcomes. We can talk about mental health outcomes, risk of substance use or alcohol abuse, even things like, to the representative's question, educational attainment and employment. We have really good evidence to suggest that trauma early in the life course undermines status attainments, like educational attainment and unemployment. Basically, if you can think of a bad outcome that you want to avoid in later life, you're probably going to find a connection to childhood trauma. Now, our work at the Institute, we've been doing a great deal of work in this area for some time. And we, back in 2013, developed a tool, an assessment tool called the Childhood Experiences Survey that was designed to measure adverse childhood experiences, including the 10 classic ACEs that the original Adverse Childhood Experience study focused on. That study focused on 5 different forms of child abuse and neglect, as well as 5 different forms of household dysfunction. Things like, again, substance use in the home, mental health problems in the home, domestic violence, incarceration, divorce and separation. All of those things are indeed bad for child development. They undermine child development, health, and well-being. But they're not the only things, potentially, that can undermine health and well-being. And so we wanted to measure some of those other sources of toxic stress. So we included other indicators, things like extreme poverty and homelessness. Having a parent that was out of your life for a long period of time, absent from your life. Experiencing the death of a parent or a sibling. Even things like bullying and violent crime, things that happen outside of your home. We know that all of these things, we know from research, are also detrimental to health and well-being, and so we wanted to measure it with this assessment tool. And we have integrated this with our partners at the Department of Children and Families and the Department of Health Services into routine practice in their Family Foundation's Home Visiting Program. The Family Foundation's Home Visiting Program is a statewide network of agencies that provides evidence-based home visiting services. You can see it's widely distributed throughout the state in 31 counties and 5 tribal regions at present. These programs are funded primarily through the federal Maternal, Infant, and Early Childhood Home Visiting Program. This is a federal funding mechanism, also known as MCV. But the program also receives additional funds through temporary assistance for needy families, as well as some additional general purpose revenue dollars through the state. This program is designed primarily to serve economically disadvantaged families, low-income families. 96% of FFHV families, 96% of the families that receive these home visiting services are low income, as defined as their eligibility for means-tested benefits like TANF or like Badger Care Plus, or they're below 200% of the poverty line. Now, I want you to keep that in mind. I'm going to show you some evidence that we've gathered. I'm going to show you some rates of trauma in this population. I want you to keep in mind who it is that we're looking at here. This is a geographically diverse sample of people spread throughout the state. It's racially and ethnically diverse. It represents that distribution, but it is homogeneous economically. These are all low-income families. And what do we see when we look at ACE rates in low-income families here in Wisconsin? These are all women, by the way, who are the primary caregivers in their home. We see that 40% of the women who are receiving these services, these home visiting services, 40% reported that they were physically abused in childhood. Over half indicated that they were exposed to substance use in the home when they were children. Well over a third had a parent or caregiver who was incarcerated or in jail. Now, I see many of you shaking your heads, and for good reason. These are astronomical numbers, and indeed, that bears out. That number alone, that 37.9%, is roughly 7 times the rate of incarceration that they found in the original Adverse Childhood Experiences study. 85% of mothers in this program report that they have experienced at least one ACE. 68%, over 2/3, reported that they experienced multiple ACEs in childhood. Now let's look at some comparative data. This slide depicts high rates of adversity, the percentage of people in the Family Foundation's home visiting program, these low-income women, the percentage that experienced 4 or more ACEs, a really high level of trauma in childhood. And it compares them to the general Wisconsin population. Here I'm reporting data that was gathered by the Child Abuse and Neglect Prevention Board. You can see that when we look at the general Wisconsin population, roughly 14% report that they were exposed to 4 or more ACEs. We see triple the rate among low-income women receiving home visiting services, 43%. What this tells us is that, yes, trauma is widely distributed in society, but it is not equally distributed in society. It is found at higher rates in low-income or otherwise disadvantaged populations. Now, the story gets worse, unfortunately, because what I was showing you before are only those 10 classic ACEs that were measured in the original Adverse Childhood Experiences study. But of course, there are other potential sources of toxic stress that we could be thinking about. Well over half of these women reported that one of their parents was out of their lives for a long period of time, not due to death. Well over a quarter indicated that they were bullied frequently, not ever bullied, bullied frequently. And nearly a quarter reported that they had been homeless in childhood. This gives you a flavor of the kind of experiences that these women and these families have had when they enter these programs. And the story gets yet worse, because while we're talking about adverse childhood experiences, and indeed they do lay a weak foundation for the rest of the life course, we don't magically cross some threshold when we turn 18 and all of a sudden the trauma stops. Many of these women continue to experience trauma once they reach adulthood. And we wanted to assess that within the context of our work in the Family Foundation's home visiting program. And so we developed a complementary tool called the Adult Experiences Survey that assesses adverse grown-up experiences. So we measure things like physical abuse and emotional abuse by a spouse or partner, mental health problems or alcohol and drug problems of a spouse or partner, as well as having a partner who was incarcerated or in jail. We also measure other things like forced sexual activity, being a crime victim, being homeless in adulthood, experiencing chronic poverty, as well as discrimination. And we've been measuring these things within the context of our Families and Children Thriving study. This is a prospective, longitudinal study of risk and resilience among the families that receive home visiting services here in Wisconsin in the FFHV program. And we've been tracking these families over some time, and indeed this fall we're going to hopefully add a third wave where we measure families once their children are 4 or 5 years of age. And this gives us some really rich insights. When you can follow people over time, you can really begin to track not only the effects of trauma or adversity, but also positive things like home visiting services. For now, I want to show you the rates of adverse grown-up experiences in this sample. You can see that 45% of these women reported they've been physically abused at some point in adulthood by a spouse or partner. 60% had been emotionally abused. Nearly half had had a spouse or a partner who was incarcerated or in jail at some point. Well over a third have been homeless in adulthood. Again, 85% we find have experienced at least one adverse grown-up experience, and roughly 70% have experienced multiple adverse grown-up experiences. Please bear in mind, the average age of the women in this sample that I'm looking at right now is 27 years. 27 years of age, and this is what they've experienced already in adulthood since age 18. Think about what these rates might look like when they're 37, 47, 57 if we don't intervene. Now, in our own research, we've also thought about the consequences of adversity over the life course. And indeed, we've replicated findings that other studies have shown, which is that adverse childhood experiences increase the risk of mental health problems in later life. Among these women in home visiting, it increases the risk of depression, anxiety, post-traumatic stress. We've also shown that adverse grown-up experiences, adult adversity, also has similar effects. In fact, almost even stronger effects associated with poor mental health. Now, what we've also shown, which is probably not surprising, is that childhood adversity also predicts adult adversity. Who are these women that are at risk of experiencing lots of adult adversity? They're often the people who've experienced lots of childhood adversity. Poverty begets poverty, trauma begets trauma, risk begets risk. And what we've also shown is that there's a causal chain. There are these causal connections over the life course whereby childhood adversity increases the risk of adult adversity, which in turn increases the risk of poor mental health. Now, for a research person like me, that's interesting scientifically, but it also has practical implications. It suggests, to me at least, that when someone experiences an adverse childhood, it's not the end of the story, right? That one is not consigned to a fate of poor mental health or other negative outcomes. That potentially, if we intervene in the years between childhood adversity and those adult mental health problems emerging, if we can intervene in ways that reduce the risk of adult adversity, potentially we can break that link, that causal chain between childhood adversity and these other negative consequences. Now, the effects of adversity are not only found, and this was raised earlier as one of the questions, the effects of adversity are not only found within our own lifetime, we're learning more and more that the effects of adversity and trauma can be passed across generations. This slide shows some data from our home visiting study using data from the Families and Children Thriving study. What it shows is that the more adverse childhood events a mother reported, the greater the risk her children were for emotional and behavioral problems early in life by 3 years of age. And we can think of many potential reasons why that might be the case. I can't go into them today, but I'd be happy to talk about them later on. The point here, though, being that trauma is not just something that happens to an individual. Potentially, trauma can be intergenerational in nature. And that brings me to applications. Answering the so what question. What is it that we can do about this issue? And I'm going to talk about one potential set of solutions. They're not the end of the discussion, but I think that home visiting represents this grand opportunity to begin to think about the kinds of environments that we want to create for families early on that can help to buffer stress in the household and as well as reduce the risk of children being exposed to trauma to begin with. So what are home visiting programs? What are these things? They're a broad class of interventions that are designed to provide in-home services and support to pregnant women and new parents. This is a two-generation approach, meaning that you're simultaneously working with a pregnant mom, right, as well as a family, right? You're working with adults, and at the same time, working with a newborn child after that child is born in order to ensure that that child gets a healthy start to life. Often these services are provided by professionals, professional health and human service providers like nurses, like social workers. Other times they can be provided by paraprofessionals as well. And what do they try to do? Again, there are many types of home visiting programs, but some of the main outcomes that they try to promote are maternal and child health, making sure that a woman when she's pregnant has a healthy pregnancy, that she has reduced levels of stress, and then once that child is born, helping to ensure that that child develops appropriately, right? Is not only healthy at birth, but also that it's raised in a positive and sensitive caregiving environment, and certainly one that is free from child abuse and neglect. And then ideally, over time, if these programs are good, they can promote long-term child development as well as even potentially school readiness. Now, you heard before Dr. Fox invoke a scientist, an economist by the name of James Heckman. He has done groundbreaking work that has used cost-benefit analysis as a way to demonstrate that these kinds of early investments in the life course are not only effective, they're cost-effective, right? Home visiting programs and other early childhood interventions are not only been shown to be effective and impactful, they've been shown to return, in terms of ROI, return on investment, return significant dollars to society based on their impact, right? And you can see this thing, it's called actually the Heckman curve, and it basically says just that. When we intervene in adolescence or early adulthood, we get some return, but we get much more when we target our resources toward the earliest years. And it's for many of the same reasons that Dr. Fox talked about in his presentation. And again, I want to come back to this theme about two-generation models. Not only are early childhood interventions worthwhile, I'm particularly fond of models that are two-generation in nature, right? Because you sort of get a two-for-one deal, right? You can have impacts on a caregiver and the caregiving environment, and those benefits can then be passed along to the child. And so when we think about home visiting and we think about the potential to impact trauma, we can think about home visiting as an intervention, something that comes in after someone who has experienced trauma, but can nevertheless benefit those adults and help to mitigate the effects of that trauma. But it's also a prevention tool. It can help to reduce the likelihood that their children are exposed to trauma to begin with. Now, as fond as I am of home visiting programs, early childhood interventions, and two-generation models, the home visiting programs that we typically implement here in Wisconsin, they're all pretty intensive, long-lasting, comprehensive services. Really effective, they can be really beneficial, but there's a public health challenge. Right? I mentioned before that trauma is widely distributed in society. It's not something that just a few unfortunate souls experience. And so the question is, how can we get these good things? If we believe that home visiting is good, and I think we should, how do we get it in the hands of more people? How do we scale it up so that it can reach a larger cross-section of the population? So I'll show you just some data briefly. Here in Wisconsin, the FFHV program from 2014 to 2016 served about 650 families per year, which is about 1% of infants that are born in Wisconsin. Now, fortunately, in recent years, we've received some additional support from the state, which is wonderful, and we've been able to bump that number up to over 1,000 families were served in 2018. Still, we're not reaching the number of families that we need potentially to move the needle, the public health needles that I'm talking about, things like child abuse and neglect. So one potential solution, and this is not the only solution, but one potential solution is to pair those comprehensive long-term services with briefer and more universal services. And one model is that I'm fond of is called Family Connects. It's a universal model. It's designed to serve all families within a particular area. So all families are eligible to receive it regardless of economic status. And it begins during a hospital visit where a nurse comes into the visiting room and says, hey, I'm here to schedule your nurse visit. Would you like to receive it? After that, and most people say yes, and I'll show you that in a minute, the nurse then goes out to the home a couple weeks later and does a comprehensive assessment in the household. They use a family support matrix, and they assess the family's strengths as well as their needs. And based on that comprehensive assessment, the nurse then has a conversation with the family about where to go from there. For most families, that single visit is going to be enough. That brief bit of reassurance, the telling a new parent that your baby's doing just fine, you're doing just fine, that's plenty. That's enough. But for those families that need a little bit more support, the nurse can provide additional support through the form of additional visits to the home, as well as warm referrals to other community-based services. And this is one of the areas in which this model shines in particular. Before you even implement this model, you have to conduct a really thorough community alignment process whereby the program identifies many referral outlets within the community. Referrals for things like health care, mental health care, child care, economic supports, and housing to ensure that when needs are identified by that nurse, the nurse can then provide that warm handoff to another community service provider that can help to meet those needs. And here again, the goal is, I use that term warm handoff or warm referral. You don't just provide the family a magnet to put on the refrigerator or a pamphlet, here's this, right? The goal is to then actually help walk that person, if they're willing, to receive those services to ensure that they actually benefit from them. So some evidence from this model. Why am I fond of it? 80% of families in the first major randomized trial of this program in Durham, North Carolina, 80% of families that were offered the program accepted the program. And of those in the hospital who said, yeah, sure, I'll schedule a home visit, 86% of those actually received a home visit, meaning that they were able to reach 2/3 of new mothers in Durham, North Carolina during the study, right? And if you want to impact people, you have to reach them. So that's one good thing. What did it do? What kind of benefits did they see from this brief universal model? They found that it was associated with significant improvements in home environment safety. Families were able to get into better quality child care. It was associated with enhanced maternal mental health outcomes, including reduced anxiety. And it was associated with increased father involvement with the child. On top of all of that, they found that this model was associated with nearly a 50% reduction in child protective service reports, as well as roughly a 50% reduction in emergency room visits, emergency health care for infants, which is sometimes used as a proxy for child abuse and neglect. So they're seeing these major benefits in areas that really matter. When you're thinking about trauma, they're seeing this, right? And they found that this brief universal model, which only costs about $500 to $700 per family to deliver, they found that based solely on those emergency room findings, that within 1 year after implementing the program, it returned $3 for every dollar invested in the program. Now, since 2017, I've been fortunate enough to partner with the Central Racine County Health Department here in Wisconsin. They're the first site in Wisconsin that's taken up this Family Connects model. The Family Connects model is now recognized by the federal McV program as an evidence-based model. And they've been able to implement that in partnership and with generous funding from the United Way of Racine County, as well as the Racine County Human Services Department. In 1 year, with 3 public health nurses, they're able to serve up to 600 families in Racine County in just 1 year. And what's really great about what they're doing, and that's so innovative, I think, is that they're actually delivering it alongside their more comprehensive long-term home visiting services. So they're sort of setting up a one-stop shop whereby the Family Connects represents, in many cases, the foot in the door. But for those families that need longer-lasting support, they can then provide that support by simply moving them over into their long-term home visiting program. Now that's the prevention side of things. This model can potentially help to prevent child abuse and neglect and other forms of adversity. But what about intervention? What can we do to be more trauma responsive while we're delivering home visiting services? I don't have all the answers to that, but I have one potential solution that we're really excited about. So recently, the health department in Racine has partnered with us at the Institute to implement a trauma screening, brief intervention, and referral to treatment model. This was developed by my colleague, Dr. Dimitri Topitsis at the University of Wisconsin-Milwaukee. This is a very brief protocol that is designed to assess trauma as well as symptoms of trauma. And then after that assessment occurs, you have a brief conversation with the caregiver, talking with them about asking them, how is it that you've been able to cope with these circumstances? How is it that you've been able to survive and even in some cases thrive despite all the adversity that you've experienced? And that, based on that brief conversation, you may begin to illuminate some helpful coping strategies and maybe some unhelpful coping strategies. And when those unhelpful coping strategies arise, you can then potentially refer them to other services in the community, including mental health services, as well as substance use and alcohol treatment services. We've implemented this in multiple sites, including pediatric care settings in Wisconsin, workforce development settings, and now we're implementing it within the context of this brief universal nurse visit program in Racine, and we're really excited about it and its potential to help adults obtain helpful services to address the trauma that they've experienced. So some brief takeaway messages. Number 1, trauma is a major public health problem. I hope I've made that case. Second, what can we do about? We can think about home visiting. Home visiting is a 2-generation strategy that has great potential, not only to prevent trauma, but also to mitigate its effects. Third, as wonderful as long-term home visiting programs are, they can't do it alone. We need some complementary strategies. Family Connects is potentially one of those strategies. It's a short-term universal model that has proven to be both effective and cost-effective. And with my magic wand, I think Wisconsin could actually develop a trauma-responsive home visiting system, a comprehensive system that combines both brief universal services as well as targeted long-term services. Thank you.